Now that we have looked at dementia more in depth, we will begin to discuss two other conditions that can be confused with dementia: delirium and depression. First, we'll look at delirium. With delirium, there are specific symptoms to watch for, which are usually different from those of the individual with dementia. These include symptoms. This onset often is related to sudden changes in the person's health. Perhaps they recently began to take a medication which does not agree with them, or they have a physical illness. There may be a fluctuation in the level of alertness and consciousness. Sometimes such patients are wide awake, oriented, and alert, yet at other times they appear confused, sleepy, and disoriented. With dementia, this changing back and forth of consciousness is rarely seen. Persons with delirium often experience visions or visual hallucinations and sometimes hear voices. The sleep-wake cycle is often reversed, with people awake at night and very sleepy during the day. A sudden onset of incoherent speech in a patient who is not in the latter phases of dementia is strongly suggestive of delirium. A physical cause which produced the delirium can often be identified. The most common causes are the following: drug effects, too much or a bad combination of drugs. Medications can produce bad side effects on specific people, or the medications may actually intoxicate some individuals and lead to confusion. Other worrisome drugs include alcohol, illegal street drugs, or over-the-counter medications. Vitamin deficiencies associated with chronic alcohol intake can also cause delirium. The effects of surgery and anesthesia on the patient's system may produce symptoms of deliria in many patients as they are recovering. Sometimes these effects can last days and weeks, even if the procedure was relatively brief. If patients with memory problems have a location change or a living situation change without adequate preparation, there can be terrific upset. This may take the form of severe confusion, disorientation, and agitation. It's easy to see this when someone suddenly has to go to the hospital or is moved to a nursing home. Other causes for delirium may be fecal impaction or urinary retention, infections such as pneumonia or urinary infections, cardiovascular problems, especially heart attacks, congestive heart failure, heart block, or heart rhythm problems, metabolic system and internal glandular problems in the regulation of physical and chemical systems in the body. One can see these problems in sugar diabetes or thyroid dysfunction, which may cause body chemistries to become very abnormal. It is possible to have a dementia and then have a delirium added to it, such as a mildly demented person whose diabetes gets out of control or who has unexpected surgery. This person may have the memory problems of dementia, as well as the sudden appearance of disorientation, sleep-wake reversal, agitation, and confusion because of the delirium. Be alert for sudden changes in all of your patients. They may be suffering from a delirium on top of dementia. Depression is often hard to distinguish from dementia. Many elderly people have a periodically depressed mood from losses and other disappointments. However, if this depressed mood is combined with other symptoms, which may include loss of interest and pleasure in their usual activities, confusion at times, and develop eating and sleeping disturbances, they may be developing a depressive illness. Other symptoms include more trouble concentrating and thoughts which are pessimistic and hopeless, or may include recurrent thoughts of death or suicide. A few generations ago, people thought that if somebody became depressed, they may have brought this on themselves, and they needed to pull themselves out of it, often by sheer willpower. We now know that a depression may be brought on by an upsetting experience, or losses, or a change in the person's nervous system which is beyond his or her control. Once a person has the symptoms of a depression for extended periods of time, the chances are extremely good that it will interfere with their functioning and may require professional help. As we mentioned, a depressed individual may appear to be indifferent to activities around them, having difficulty concentrating on current events, and therefore look as if they have memory problems, or they may appear and act confused. Because people with depression can look as if they have dementia, it is extremely important that these individuals have a complete assessment to determine if they might have a depression rather than a dementing illness. Depression is treatable with medication and psychotherapy and can have a very positive outcome. Other important symptoms leading to the diagnosis of a depressive illness include an appetite change, usually a decrease in appetite. This appetite loss is often accompanied by weight loss and constipation. A sleep disturbance, usually having trouble sleeping throughout the night, waking up excessively early, or having very restless sleep. A loss of energy, fatigue, apathy, and inactivity are also common symptoms. Not having enough energy to get up and cook, or eat, or even to get dressed are often symptoms of depression. As we mentioned before, there are a number of thinking changes associated with depression. An early change is having trouble concentrating, even on things one used to enjoy, such as reading or watching TV. Another change is becoming very pessimistic, feeling hopeless, wishing one were dead, or even having recurrent thoughts about death or suicide. Sometimes dementia and depression can exist together. About 1/3 of all individuals with dementia, especially in the early stages of dementia, also have a depression. A clinical depression is extremely common after someone has had a stroke. Caring for a person with dementia, delirium, or depression, especially when 2 or more of these conditions coexist, is difficult. That is why it is important for you to begin to recognize differences between them. By knowing their symptoms, you may be able to have the patient evaluated and help correct the problems, and hopefully make your job a bit easier. The next section will familiarize you with how dementia is diagnosed. Dementia, delirium, and depression share many symptoms in common. Thus far, we've been describing these conditions and how they affect patients. Now, let's look at assessment procedures which can help distinguish between them. First, a comprehensive physical examination with laboratory studies should be conducted to determine if a person might have a treatable medical condition or physical problems which might be causing the confusion or behavior change. For example, 2 commonly missed treatable conditions that can look like dementia are high blood pressure and anemia. Laboratory studies to rule out such treatable conditions include a blood count, urinalysis, and blood chemistry screening tests to assess liver, kidney, and thyroid functioning. Tests to rule out vitamin deficiencies are also useful. X-rays of the head, such as CT scans, may be required depending on the patient's history and the results of the physical examination. Problems with hearing or vision that may be causing the patient to become confused or disoriented should also be assessed.
I'm very worried about Fred. He's very forgetful lately. Sometimes he just doesn't seem to remember who I am. He says, "Who are you?"
A clinical interview with the patient and the family by a trained geriatric professional, such as a physician, psychologist, social worker, or other healthcare professional, is also a crucial part of assessment. Whenever possible, family or others knowledgeable about the patient need to be interviewed to obtain accurate information about the patient. Patients with memory problems often cannot answer these questions accurately. The clinical interview is a series of questions that provides a history of the problems the patient is having and identifies types of changes that have occurred in the patient's life. For example, the interviewer asks when the patient's symptoms began, what they are, how gradually or suddenly they progressed, and what additional emotional, behavioral, physical, or social problems are evident. Gathering a history of drug and alcohol use, all medication use, including over-the-counter medication, is also necessary. Each of these can affect thinking and alter mood. A patient may have several different doctors, all giving prescriptions for medications that may react badly when combined. The patient may also be taking over-the-counter medications on top of their prescription drugs. Using combinations of prescription drugs and those bought over-the-counter can add up to trouble for the patient. Mental tests are also done to determine whether the patient is actually having memory problems and how severe these problems are. Let's start with the beginning. What year is it now?
1990.
1990. Right, right. And what month are we in?
June?
June. These tests, called neuropsychological tests or mental status questions, evaluate memory and other areas of thinking, such as language and judgment. The interviewer assesses mental function by asking questions directly from the patient from a standard screening test, such as the one you are seeing here. Or a qualified psychologist may assess mental function by a more detailed battery of tests designed to provide more specific answers about patient diagnosis and treatment. For the patient living at home, an environmental assessment at the patient's home is important. This assessment will determine if the patient's home is safe and secure for them at their current level of functioning, or if changes need to be made to allow them to remain at home and in their community. This assessment also looks at the patient's ability to do activities of daily living. In other words, are they able to take care of their own needs, such as cooking, cleaning, dressing, and personal hygiene? If the person is having difficulty with some of these activities, they will need assistance. They may need to have a live-in companion to assist in cooking, giving medications, cleaning, or providing transportation. Or they may need nursing home placement. Gathering a detailed history of environmental changes, such as moving to a new location or recent losses, is also important. After these sorts of changes in the patient's life, relatives will often report mood changes, or they may report that the patient is expressing feelings of hopelessness or interest in suicide. All of this, the physical examination, the clinical interview with the family and the patient, the mental examination, and the environmental assessment will help in evaluating whether a person has dementia, delirium, depression, or a